All right, so any questions from stuff on whatever day it was, Tuesday, I believe? What do we cover? We cover the obstetrics section of this. It feels pretty comfortable treating a pregnant woman. One thing I want to clarify from lab from yesterday, there's some question about when you say like extra strength Tylenol, that's always a question that comes up because there are different varieties, and it's kind of an inherent issue with over-the-counter products is like the naming conventions kind of are very they're very loose with it. So like when you see Tylenol, like what does that refer to, do you think? You think it's acetaminophen, right? But there's Tylenol PM, there's Tylenol, different cough and cold products that, can have any different combination of medications in them. That's why it's really important to specify. So like, especially from a poison control standpoint, when someone calls up and they say, oh, my kid accidentally took too much Tylenol, you have to clarify to be like, okay, well, what product was it? Was it, what specific, what does it say on the box? Or what does it say on the actual ingredients? Because if you miss something, that could be problematic, right? So there are couple of different strengths of Tylenol that are available. There's the 325s, which are pretty standard kind of dose. You will see some nomenclature that will say extra strength will say 500, but there's also a higher one that's 650. And so if you don't know what type they took, I always assume the max, just that way I can make sure I don't exceed that 4-gram limit in a day, especially if they're taking other pain medications on top of that, which may contain Tylenol. For instance, we talked about what drug yesterday. Yeah, Percocets, which has like oxycodone and acetaminophen. I always make sure that I take that into account. If I don't know what type they're taking, I just assume 650 until proven otherwise. The 650s are kind of interesting because they're, I guess not probably not interesting to you guys, but they're usually marketed more for like arthritis, like osteoarthritis, and so they actually are given every 8 hours, and the reason for that is it's actually a 325 Tylenol wrapped up in another 325, and they dissolve at different rates, so that way you get kind of this biphasic peak that occurs there, and the idea is you get a little bit longer sort of pain control, so it's kind of like a pseudo controlled release sort of format. But anyway, hopefully that clears things up for everyone. Again, you may see extra strength referring to either the 500 or 650. It just depends on the labeling, and especially when you go with generics, like who knows what they're, it's kind of the Wild West from that standpoint. Anyway, so continuing to talk about our feminine concerns, we have our estrogens and progestins we're going to talk about here. You guys have covered this in CMS already, correct? You know a lot about the female cycle, the menstrual cycle. I really want to take this, and if you have any, I want to take it from being a question mark and turn it into a period, right? Sometimes it's an exclamation point, but okay, anyway. So we have the menstrual cycle, right? So we have this hypothalamic pituitary axis, which we are very familiar with. We've covered it kind of ad nauseum, I'm sure, in several different classes. But the main components here, we'll talk about drugs that are affecting all these different points here. Obviously, we have the hypothalamus, which is releasing our gonadotropin-releasing hormone. Certainly, we have some drugs that are analogs of that will be used. We'll talk about that a little bit later. And then the two primary components here we're going to be referencing are going to be the luteinizing hormone and follicle stimulating hormone. Those then go down to the ovary, which should be stimulating release of things like estradiol. We'll also see progesterone are going to be secreted here as well. And so we'll look at the different varieties of estrogen and how those can have different effects throughout the body. We'll look at some drugs that can either mimic that or try to prevent maybe even production of this. So everyone familiar with this, right? And know that there's a negative feedback inhibition that can happen here. So if I were to give, say, extra estradiol or some sort of substitute of estradiol, what is that going to do to the rest of the system? Should shut it down, right? So for instance, we're giving something like oral contraceptives, like we're giving doses of estrogen, which are usually going to be supraphysiologic in a lot of cases, that are hopefully going to feedback and shut down the hypothalamus and the pituitary. So that way, if you don't have that LH and FSH being released, there should really be an ovulation that occurs there. And that is the goal, to prevent ovulations. That way you don't have a conception occur. So, and again, looking at the normal cycle, you'll see this is your LH and FSH occurring here, where you talk about that spike that occurs around 14 days. This is usually when you have that ova being released, when ovulation's occurring. And again, you will see that a lot of things like side effects can be related back to, especially things like oral contraceptives, can be related back to the estrogen levels that you're administering. We'll talk about that, where you have too low estrogen levels, you can see some bleeding issues, and if it's too high, you can also see some issues as well. So we'll talk about those, but typically around day 14 or so is when you get your highest peaks of estradiol. Then it will drop off pretty precipitously, and that's when progesterone is going to build back up to higher levels. And so you'll actually find that in a lot of cases, do oral contraceptives, they come at the same dose every single day? No, they typically have, you'll find that they can have different phases associated with them. Some of them will actually be the same dose every single day, but in a lot of cases you'll find that they try to mimic the natural cycle to some degree. So when you hear about things like they're biphasic or triphasic, that's what that's referencing. It's trying to make it more similar to what the actual natural body processes would be, but still preventing ovulation from occurring. And so you'll see that the doses will change. The estrogens will kind of gradually go up through, the first and second week, and then we'll taper back down. And then usually the last 7 days of any oral contraceptive pack is usually placebo, right? So that way you have that withdrawal period that occurs, take away all the estrogen, and then you can have that sloughing off of the endometrium and have a normal sort of a period. Okay. So we see there's lots of disturbances in ovarian function that can occur, very common events, and could be inflammatory issues, could be neoplastic issues that pop up here. We'll talk about ways that we can influence that with some of our hormones, but you'll normally find that a lot of minor disturbances can be self-limited. So if you imagine things like emotional stress can actually affect gonadotropin releasing hormone secretion. You'll also find, sorry, my phone's off. All right. You'll also find that like extremes in diet and exercise can affect this as well. So if you're like in a really malnourished state, typically your body's not super concerned with having a child, and so it will kind of shut a lot of these processes down until nutrition comes back or exercise is a little bit more limited, things like that. So the major estrogens we're going to deal with, the primary one that you'll see being secreted by the ovaries is going to be estradiol. We'll look at the process and how that actually gets formed in just a little bit. And then you also have estrone and estriol. They typically get converted either in the liver. And the liver is going to be a big place where we're going to see a lot of estrogen effect happening here. And then also in the periphery, you'll have some conversion that happens as well. Now, equine estrogens come from what type of animal, might you guess? From horses, right? Any horse pajamas today? Okay, that's good. So they actually produce some estrogens, and you might not think this, but there's enough cross-reactivity where we can actually get estrogen effect from having equine hormones being given to people. And so the quelinin and equelin are the two primary ones here. And before we had synthetic estrogens that we could administer to people, we actually would use pregnant mare urine, because they found that pregnant mares tend to have higher levels of estrogen. You could collect their urine and you could isolate that out, and then you can administer it to people. So whenever you see the term Premarin or the name Premarin, that's where that comes from, is pregnant mare urine. So kind of interesting sources for some of these drugs. Nowadays we have better synthetic processes to produce a lot of these, but this is where the drug actually originates from. So looking at the different hormones that are being made here, the kind of the process we see in the follicular phase, this is where you have this androstenedione being formed. This is a precursor to testosterone as well. And they also have the luteal phase, some progesterone being formed here. Aromatase is going to be a big enzyme. We've kind of alluded to this previously. I think we mentioned that in the chemo section briefly. Aromatase is a very important enzyme here. When you have this occurring, it's going to get converted over to estrone and then eventually to that 17-beta estradiol. That's the primary kind of mover and shaker within the ovaries from an estrogen perspective.
Chemically than human estrogen?
Is what one?
Is it the equine, the horse?
It's structurally different, but it still has enough homology with this structure here that it will work. And I'll show you some of the synthetic ones in another slide. You'll see that there's enough, even though they're a little bit different, they can still interact with those receptors at the nuclear level. And this is where you can see with a lot of the side effects that can come about from monkeying around with some of these enzymes. So for instance, if I were to inhibit aromatase, what do you think that would do as far from an androgen versus estrogen sort of balance? Tip it more towards the androgen side, right? Because again, if you're kind of blocking this enzyme process, you still have this androstenedione being formed, but it's going to be shunted more towards the testosterone side, and that's where you're going to get side effects like the hirsutism, you get voice changes and lipid changes and all kinds of other issues that occur from having higher testosterone levels. But normally, this is what should be forming here. And again, some of this estriol, this estrone can get formed out in the liver and the periphery as well. We'll see that the liver is going to be a main site for a lot of side effects of these estrogens, as we'll see just a little bit. So here are, again, some of the natural steroidal estrogens that are formed within the body. So estradiol, again, being the primary one. You can see here some of the synthetic ones that we have. They still share that same kind of core steroid structure, but they just kind of some different side chains there. And so ethinyl estradiol is probably one of the more common ones you're going to see in a lot of products, especially for oral contraceptive use. There are some synthetic ones that are being used. We probably won't talk about these too much, but the main synthetic estrogens you're going to run into from a drug standpoint is going to be ethinyl estradiol, some micronized estradiol out there, and then there are a few different salt forms that are available. You also see, especially for hormone replacement therapy. When do you use hormone replacement therapy typically? Yeah, women during menopause. So once their ovaries have stopped producing their own estrogen, we can replace that. And this is where you're going to see these conjugated estrogens. So these are typically like mixtures of estrogenic compounds, but this is how you'll see it being written for, or how you'll see the drug being called, is just conjugated estrogens. So these typically are going to be highly protein-bound sort of molecules. They will bind to either albumin or alpha-2 globulin, which is also known as sex hormone binding globulin, which kind of makes sense if you imagine it binding to estrogen there. And again, that estradiol will get converted into different sites. And so you'll see some different activities there. That makes sense because when we talked about testosterone, that gets converted into what? Yeah, there's that 5-alpha reductase enzyme that converts it to DHT, or that dihydrotestosterone. That actually has more androgenic properties than testosterone. So again, just keep in mind there's going to be a little bit of difference in activity between these different ones, which I probably won't get too deep into. But the big thing to note here is these conjugated metabolites end up getting excreted in the bile. So a lot of the estrogens that are produced will go through the liver, that will get metabolized and then usually conjugated to make them more easily sent out through the biliary tract. And that's going to be important because when you actually get those sent out into the GI tract, they'll have this they'll get hydrolyzed. They will then become active again and then can actually be reabsorbed. So we've already talked about some cases where you can actually interrupt this. So what is required for the hydrolysis to happen? No. There's actually gut bacteria that can do that, right? So when we mentioned there's an important side effect with certain antibiotics, right, that can actually potentially interfere with the efficacy of oral contraceptives. And that makes sense now, because if I can't hydrolyze that and I can't have that recycling and that reabsorption, then that will do what to my estrogen levels? They could drop, right? And then all of a sudden I may not have that good suppression on the the hypothalamus and the pituitary. If I don't have that suppression, then ovulation is possible, right? So again, that's one of those theoretical concerns of interactions, why you might recommend using a backup form of contraception due to interrupting that. Anyone know what we call this when you have drugs being sent out through the biliary tract and then being reabsorbed through the GI tract? Enterohepatic recycling, and that's an important thing to remember, because several drugs will do that, and if you mess up with that, or if you interrupt that, then you can see those levels drop. We actually will do that therapeutically with some drugs. So for instance, something like phenytoin undergoes a little bit of this enterohepatic recycling. We can actually use things like charcoal as it gets kicked out into the GI tract. We'll bind it up with charcoal, and then it'll get eliminated through the feces. So we'll do that from a tox standpoint to drive levels down a little bit quicker. So just some examples. The other thing you'll see is that because they're primarily metabolized in the liver, you're going to see a high ratio of, especially orally administered contraceptives or estrogens, a high ratio of adverse effects from the hepatic standpoint versus these kind of peripheral effects. We're going to see the adverse effects we'll talk about in just a moment here, but you'll see, and this is important, that picking the right dosage form for your patient can be very important to mitigate some of these side effects. So for instance, if I were just to give, say, an estrogen product vaginally, that limits, you'll get some systemic absorption, but not nearly to the degree that I would see if I were to give an estrogen product IV, or if I were to give it orally and it goes to the liver. Additionally, if I had like a transdermal product, you also miss a lot of that hepatic interactions, because you miss, what is that term that when drugs hit the liver first before they get to the systemic circulation? First pass, yeah. So again, the side effects can occur due to that kind of first pass effect that happens there. And so you can interrupt that by using things via different routes. So vaginally, transdermally, sometimes we'll see like certain ones will be given via injection, and that will also help to mitigate some of those hepatic effects as well. So how do the estrogens actually work? They're going to get down to the nucleus. They're going to bind to these across the cell membrane, bind to these estrogen response elements. Usually, it will dimerize, and then it will affect some degree of transcription, translation that occurs. So different proteins will be formed, different cell signaling pathways will be kind of activated or inhibited based on that. And this is important because these different response elements that they're binding to are going to differ between tissue to tissue. So the effect that estrogen has, or this will be important when we talk about different drugs, those selective estrogen receptor modulators. You guys remember when we mentioned those? Right, so you'll have some drugs that can act as a proestrogen sort of molecule in the breast tissue, but be an antagonist in the ovaries, or vice versa. And so we'll look at some drugs that can do that a little bit later, kind of refresh ourselves on those. But that can be important. And obviously, the estrogen effect in the uterine tissue is going to be different than the breast tissue versus in the bones versus in the on your lipids and things like that. So again, you're going to have a wide variety of activities based on the type of tissue you're dealing with. So the clinical effects you'd expect to see from these estrogens, you see a lot of female growth and sexual maturation, so a lot of development of their sex organs and things like that. This is where you also see a lot of hair growth and body fat distribution, growth of bones and things like that all get affected by our estrogens. And then we'll also see some endometrial effects here as well. And so this is, again, why you end up seeing development of the endometrial lining is due to the estrogen effect. That tissue starts to build up and starts to hypertrophy. And then when you take away that estrogen, what happens? It wants to go back to normal, so it tries to slough off a lot of tissue. And again, that's why we have menstruation that occurs there. Now, again, you have to have this interaction between estrogen and progesterone because it's going to be kind of a seesaw effect. And you saw that early on in the cycle, around week 2 is when you see your estrogen peak effects, and then progesterone kind of takes over. And it's important to have that cycling that occurs there because progesterone kind of keeps things in check and make sure that the endometrium doesn't continue kind of growing ad infinitum, because if that occurs, what could happen? Endometriosis and then eventually endometrial cancer, right? So that's unchecked growth we can see there. So again, that's why we'll see that some treatments for endometrial cancer are estrogen blocking sort of agents, right? So if you have kind of unopposed estrogen effects, you'll find that you'll have this kind of abnormal bleeding due to the hyperplasia that's occurring there in that tissue. That's why typically you'll see for contraceptive purposes, you can have progesterone-only products. We'll talk more about progestins in just a second, but you really don't see estrogen-only products for contraceptive purposes because you need to have basically that back of the progesterone. You at least have to have that on board. Otherwise, you're going to just have kind of unchecked growth of that tissue and hyperplasia, and that's no good. So you'll see that there's several metabolic effects that occur with estrogens. So certainly normal structure and function, things like the skin, blood vessels are important. Have important effects from estrogen here. And you also see decreased bone resorption. So this is really important looking at especially older women, especially postmenopausal women, because a big concern from them from a bone standpoint is osteoporosis, right? So you can see osteoporosis. And so having that loss of estrogen effect, you see more osteoclast activity or having more resorption of that bone. So actually by having the estrogen around, that's why some of the thoughts is if you have something that can be a pro-estrogen sort of agent for those postmenopausal women, they should have better bone density because they're causing apoptosis and some of those osteoclasts and antagonizing parathyroid hormone, which we know parathyroid hormone normally stimulates osteoclast activity to liberate some calcium from the bone there. So you also see some adipose tissue development, higher serum protein levels. Again, this is primarily due to the liver effects. So we know the cholesterol and things like that are primarily produced within the liver. And then you'll see things like increases in HDL, reduction in total plasma cholesterol, and also increased triglycerides. So there's just some typical metabolic effects you'll find with these. The other big things, and again, when you think about like a young female patient, say she's like 17, 18, she comes in and she has a PE. What's one of your first questions you want to ask? Do you take birth control, right? And this is why we're worried about that because, and we also said that pregnant women, they also are in a hypercoagulable state. A lot of it goes back to the estrogen effects, especially in the liver, because in the liver is where we produce our clotting factors. Yeah, absolutely. So if you don't have your clotting factors are getting stimulated, you have more estrogen effects, and this is why I have this kind of hypercoagulability that occurs here. So see things like 2, 7, 9, and 10, which if you think back to warfarin, those are the primary clotting factors that get influenced by warfarin. You also see some decreased activity of antithrombin 3. You guys remember what drug works with antithrombin 3? A lot of our heparins work with that. So remember, it helps to, heparin makes antithrombin 3 work a little bit faster to inactivate a lot of clotting factors. So pretty significant effects here. That's why if you see kind of a young female who has unprovoked sort of PE or DVT, like you always think oral contraceptives typically. Also, some other effects, you can see some changes in mood and libido happen from this. And then also you'll see that this will produce some edema and fluid retention. The important thing to note here is that these hormones don't necessarily have 100% specificity just to estrogen receptors. There's also some bleed over with other steroid type of effects. So think about your glucocorticoids, think about your mineralocorticoids. So specifically with the mineralocorticoids, what do those do? Or what's our primary mineralocorticoid that we have our body produces? Aldosterone, good. Now, aldosterone typically does what to fluid status? An increase, right? You want to hold on to more water, you want to hold on to more salt. So if you have estrogens that have a high activity or that have some bleed over and they're affecting those mineralocorticoid receptors, this is where you're going to see some fluid retention and salt retention due to that, right? We're actually going to find that this is going to be more important from a progesterone standpoint. We'll find that when we're talking about different products, oftentimes you're basing your drug selection based on the progesterone activity at these mineralocorticoid receptors. We'll talk about that a little bit later as well. So primary uses, so you can use this for primary hypogonadism. So if you're just kind of replacing what a patient might not be producing. So again, if they had some issue where they have like a pituitary tumor that must be removed or something like that, where they're not really having their own estrogen being expressed, and you can replace it with this. Typically you would start it around the time that normal puberty would be occurring anyway, and hopefully it will help to develop those secondary sex characteristics, help with the bones and things like that. So typically you would give it, say on days 1 through 21 of the cycle, and that's when typically you'd see those big drops in your estrogen levels, and that would help to kind of replicate what a normal cycle would look like for that patient. And then we'll mention that the progesterone would be added on after that first uterine bleeding, again, because progesterone typically has more of an inhibitory effect on uterine tissue, and so once they had that first kind of menses, this is where you can add on a progestin afterwards. You may use this for postmenopausal hormonal therapy. What are some like effects that you see from like women in menopause? What are some of those clinical signs and symptoms you might run into? Hot flashes, right? So there's some vasomotor symptoms that occur there. My mom always called them power surges. Thought it was a much more positive spin on things. But you'll see a lot of negative effects on bone. You'll see a lot of negative effects on the lipids, things like that. So potentially you could use this for hormonal replacement therapy. Well, what kind of happens with the vaginal tissue when you have a menopausal woman? Yeah, you get atrophy of the tissue, they get dyspareunia, they get vaginal dryness, and so this is where we're going to see that we can get some benefits from using kind of locally administered estrogen products a little bit later. So we'll talk about dosage forms again and more specifically. But for these menopausal women, you'll see these vasomotor symptoms, sleep disturbances, genital atrophy. So I already mentioned those. You also see that acceleration of the bone loss. So again, osteoporosis can be pretty bad, especially if they have a fall and they have a fracture. It can be pretty devastating to those patients. So I'm going to watch out for that. And then we mentioned some changes in atherosclerosis and your serum lipids. So you'll find that LDL tends to increase a little bit and LDL receptors decrease. Remember, we want more LDL receptors because that's what's going to help the liver to clear those from the blood. So that's going to be a negative effect there. And for a while, estrogen was thought to be kind of cardioprotective, but they found they had a big women's health initiative study that really showed no benefit and actually some possible increased risk there. So again, you have to be selective about what type of products you're going to use depending on your patient characteristics. If they have a high cardiovascular history, risk history, maybe giving systemic estrogens may not be a good option for them, and maybe local products would be better. So we'll look at that selection later. So again, you have to look at things like breast cancer risk. So obviously, if you're giving an estrogen-based product, if they have a history of estrogen receptor-sensitive breast cancer in their family history, that's something you have to be concerned about. Because if I'm giving them that kind of additional estrogen effect, you can see development of that tissue, just similar to we saw. The uterine tissue will develop with exposure to estrogen. Same thing can happen to the breast tissue as well. So. Again, you're going to find that by using transdermal or vaginal estrogens, with the vaginal products, you kind of limit systemic absorption and you get much more kind of a local effect. So that will limit some of those systemic effects there. And then transdermal products will also mitigate a lot of that hepatic metabolism that occurs there. And so you don't get as much of that conversion over. So that tends to help out with some of those risks. And then you try to use the lowest dose possible for symptom management. Because again, you have to think about with postmenopausal women, you're just replacing what hormones their body would have been producing otherwise, But on the other hand, when you're thinking like contraceptive purposes, like you're trying to shut that whole system down. So typically your doses, your estrogen effects are a lot higher because you want to make sure you're inhibiting ovulation to your best benefit. Here for these women, you want to use as low a dose as possible to try to mitigate some of those negative side effects, but you kind of get the clinical efficacy you're looking for. That makes sense. Now, typically, most patients, if they still have the uterus intact, then you do not want to give them estrogens alone because of that worry of getting hyperplasia of that tissue, eventual cancer risk. However, if they have a history of like a hysterectomy, you could just give them estrogens alone. You wouldn't need the progestins at that point to reduce that cancer risk. So that's one thing to consider is like, okay, does my patient still have that intact? If not, then I can go ahead and give estrogens kind of unopposed at that point. Otherwise, you have to include it with a progestin. That makes sense? If I say anything that doesn't line up with what's in your other classes, just like give me a shout out and I'll try to reconcile that if I can. Otherwise, I'll be like, I don't know, maybe I'm wrong. But so again, with the osteoporosis standpoint, again, you can use these hormones for prevention or treatment. You need to make sure that they have good vitamin D and calcium intake. If that's not, they're just like similar to thinking about like stimulating erythropoiesis. If you don't have iron around, doesn't matter how much EPO I give them, they're not really going to be able to produce hemoglobin. Same thing goes here. It doesn't matter if they, if I give them as much estrogen as I want, if their calcium and vitamin D status aren't good, the bones aren't really going to be able to overcome the parathyroid effect and whatnot. So Exercise is also really good for them to make sure they're keeping that in check. And typically, you're going to find like thin Caucasian smokers who are inactive and low calcium intake tend to be like the biggest risk patients for fractures and osteoporosis. So those are the ones that probably need to have the biggest intervention from that standpoint. And then I mentioned that topical preparations are good, especially if you're just having like atrophic vaginitis alone. So you're just having vaginal symptoms, just use a vaginal-based product, and that's going to limit a lot of those systemic effects we're worried about. Okay, other things, ovulation suppression. So this can be useful for contraception prophylaxis, and then also for intractable dysmenorrhea, this can be useful as well to kind of shut down that system to limit that effect of the LH and FSH, because those levels should go down in response to having these estrogens on board. And in some cases, you may see suppression of ovarian function and treatment amenorrhea, and you also see some hirsutism due to the kind of excessive androgen secretion. So by giving, again, shutting down that whole pathway, that can also help to decrease the amount of androgens that are being produced there. So that's one other use you may see. Okay, so the adverse effects of estrogen. So it sounds great, but we've kind of alluded to some of the side effects. Certainly can see postmenopausal uterine bleeding. This tends to be one of the biggest causes for this, and one of the things you have to think about is kind of unprovoked, bleeding. You always have to think about the scary stuff. You have to think about cancer and things like that. So you want to rule those out, obviously, but that is an effect you can see with that. This can be mitigated by just using the lowest dose of estrogen possible for those patients, and then also if you can give them cyclically, because again, if you have like a postmenopausal woman, you don't really need to worry about them having like a normal cycle, so to speak. They're not really trying to ovulate anymore. So you can give them, estrogen progestin, the same dose, forever, and it's really not going to be an issue. But in some cases, they are having the bleeding issues. You can actually try to schedule out like a typical withdrawal, like a 7-day withdrawal period that would, kind of mimic a normal cycle. That way, it kind of gets back to normal a little bit for those patients. But again, you prevent a lot of that endometrial hyperplasia by giving the progestin. If they don't have any endometrium left, you don't really have to worry about the progestin at that point. I mentioned cancer risk. So again, you see increased risk of breast cancer with prolonged use. Progestins don't really affect this. So again, if they have a high risk of breast cancer based on family history, based on genetics, because again, some breast cancers tend to be more estrogen receptor sensitive than others. This is where we can use things like SERMs, or the selective estrogen receptor modulators, for high risk patients. You think about like tamoxifen is a good one because it was, or one of our first ones, because it acts as an antagonist in the breast tissue, but it can act as an agonist in other tissues, right? Endometrial carcinoma, we can prevent this by giving a progestin typically, so you want to make sure that co-administration is happening there. And then some risk of adenocarcinoma. This is kind of an interesting one. So these women were developing this adenocarcinoma, and they couldn't really figure out why. They didn't really have, it was one of these epidemiologic sort of studies they had to do to try to figure out what was going on, and actually found out that it was related back to the maternal use of this synthetic estrogen called diethylstilbestrol. And so this is now labeled a very strong carcinogen, not just for the patient taking it, but for their offspring. And so it's one of those things where they had to outlaw its use basically for use as a contraceptive sort of product. Other effects you can see, some nausea and vomiting associated with this. Some people tend to do better with this than others. You can try to switch up your estrogen product. They may respond to it better. It just depends. You will see some breast tenderness, and that makes sense based on your estrogen activity at the breast tissue does make it hypertrophy typically. Hyperpigmentation. Some people have worse migraines. I mentioned cholestasis, which makes sense based on the elimination of the estrogens. They have to go through the liver and get sent out through the biliary tract. So that makes sense. Some risk for hypertension. A lot of it goes back to those mineralocorticoid effects, to holding on to more fluid, whatnot. And again, just use the lowest dose you can get away with. That's always going to be your always going to be safe if you try to go with the lowest dose possible. So contraindications, you don't want to use estrogens if they have any kind of estrogen-dependent neoplasms. That makes pretty good sense there. Any kind of undiagnosed genital bleeding, because then at that point you're worried about cancer, right? So we're going to figure out if that's actually cancer or not. Liver disease is kind of a relative contraindication. So again, if you're worried about them having worsened cholestasis, it may not be the best product for them. And then if they have any known thromboembolic disorders. Again, if you're always going to see the biggest effects on coagulation with oral contraceptives. You generally get around that by either using non-estrogen based products like progesterone only products, or using something like a shot. Think about like a depot shot or like an intrauterine device, something like that. They're going to be better at limiting a lot of those sort of effects. And heavy smokers, they also tend to be more at risk for cancer, for clots as well. They tend to be more hypercoagulable and at risk for osteoporosis and things like that. So on the flip side of that, then we have progestin. And so progesterone is going to be the most important one that humans secrete, and you're going to see that it's a precursor molecule. If you go back to that slide where you kind of saw the genesis of estrogen and whatnot, progesterone is kind of higher up on the chain there, and so it's used as a precursor to androgens, adrenocorticosteroids, and you'll see it produced not only in the ovaries but also produced in the male testes, adrenal cortex. So progesterone is kind of produced in several places, and you'll see that the synthetic ones that we have, and I mentioned when you're selecting like an oral contraceptive product, like this is the biggest selection difference you have in different products is what progesterone you're going to use, and so you're going to find a wide variety of effects here because it does share that kind of precursor. It is not as specialized as you would see like an estrogen. So you can see it interacting with things like the adrenal gland. You can see it interacting with different tissues, and so we'll look at those side effects in just a little bit. So historical problem with progestins, you'll find that they also tend to have activity at androgen receptors and also those mineralocorticoid receptors. So this is what I refer to AR and MR is going to be androgen receptors and those mineralocorticoid receptors. So these are the primary side effects you're worried about. And so these are some of the more common progestins you're going to run into. So you have things like norgestrel and levonorgestrel. So again, this is just the enantiomer of norgestrel. You find high androgen receptor activity here. So what do you think that might cause? Hirsutism might be one. Maybe worse than acne could be one thing, maybe. So typically there's more kind of androgenic effects, more kind of masculinizing sort of effects. And typically, women don't want masculinizing effects for the most part. So that may be problematic. Not everyone's going to have these to the point where they're going to be intolerable, but some people may not respond super well to them. But these are some of the ones that have been around. Norethindrone's another one that's been around for a good long time. You'll find a lot of different oral contraceptive products have these included in that. But you can have different ones that may have different activities. So for instance, you can have drospirenone, and this is where you're going to find that like in Yasmin and Yaz are probably the most I think those are the first ones that had drospirenone in them. This actually has anti-mineralocorticoid effects and anti-androgenic effects, which is kind of beneficial for a lot of patients. Now, from the mineralocorticoid side, if I interact with those receptors, what do you think you would see? Similar to aldosterone, you should expect to see fluid retention and edema that can happen with that. So actually, if I have anti-mineralocorticoid receptor effects, you should have what? You should have mild diuresis. You should have some actual weight loss that can occur with that. So again, some people really prefer that. This is why drospirenone it became pretty popular due to these effects being an anti-mineralocorticoid and anti-androgen receptor activity there. Yes, ma'am. So this is the more progestin receptor. So this is more specific for the progesterone receptor versus the androgen. So again, norethindrone is another very common one you're going to find in a lot of different products. And so again, how many different oral contraceptive products are out there? There's like 3 gazillion. Whether they're monophasic, biphasic, triphasic, whether they're given continuously, whether they're given to where you only have like say 4 menses a year, all these different androgen progestins you have in here. There's a lot of different products out there, and so again, I always a patient can tell me they're on ortho, tricycline, something or other. I always just look at what the generic is because that kind of helps me give them a better idea of what's actually in the product. And again, I think I forgot to post it. I'll post a document that's all the different oral contraceptive products that are available, just to give you an idea of just how many there are and the different sort of, we'll talk about the different ways you can kind of skew these as far as like how the dosing goes and whatnot. But you'll see there's a lot of them out there. You just have to look at the generic and look at the dosing to see what type of product it is specifically. Some of them will try to give it in the name. So if you see like a orthotricycline, you think it's a tricyclic sort of one, triphasic sort of one. So those are things you can kind of get a feel for over time. Typically, providers, if you're going to be prescribing it, you get 1 or 2 or 3 that you're kind of like your go-to ones. You really don't deviate from that unless the patient really has problems with it, right? So, looking at the kinetics of the progesterone, you don't really see as many of the kind of the nasty side effects from a cancer standpoint or from a coagulation standpoint as you do with the estrogens. And again, you can use progesterones by themselves. Those are going to be potent enough and if dosed appropriately to inhibit ovulation. So you can use these by themselves as a prevention for contraception or as a contraceptive. Not so for estrogen. You need to, if you're going to give estrogen, typically if the patient still has a uterus, and you have to give progesterone along with it. Otherwise, you can give progesterone by itself in a lot of these cases. Again, they're going to work the same activity as estrogen. They have to get down to the nuclear level, work on those gene transcription sites to alter protein production and different cell signaling pathways there. They're just going to be binding to progesterone response elements rather than estrogen response elements. So they don't really have too big of an effect on lipids. You may actually see some increased basal insulin levels, so you may see some effects here, and may modify some insulin response to glucose. So maybe one thing you might see with some patients. And again, I mentioned they will compete with aldosterone in the kidney, and that's that mineralocorticoid effect we're kind of referring to right there. And they may lead to actual increased release of aldosterone, because if they're sensing, the receptors are sensing they're not really getting enough signal, they may try to get the kidney to send out more, the adrenal gland to send out more aldosterone. So you'll also find those maturation and secretory changes in the endometrium, as we mentioned. And then with our synthetic agents, typically we'd like to have minimal androgenic effects that will help to decrease that anabolic activity and will help to reduce a lot of the side effects, as we mentioned. Okay, so where do we use these? Typically, we'll use them for hormone replacement therapy, especially if the patient still has an intact uterus. You want to give this along with the estrogen, and then for long-term ovarian suppression. You can use, these large parenteral doses is where your Depo-Provera comes in to play. So you have things like medroxyprogesterone acetate. That is Depo-Provera, and that is the shot you can give actually intramuscularly every 90 days. And they would just go through every 3 months and just get another shot, and they should be good to go. What type of patients is that good for? Yeah, non-compliant patients might be a good one. Anyone else? So maybe people have like a history of like estrogen receptor, like breast cancer, and you don't want to give them estrogen-based products. This might be a good one to give. These are just things to consider when you're trying to figure out what's kind of the best contraception for your patient. Also, think about patients who are may practice high-risk sexual behaviors, and you'd like to make sure that they do not get pregnant. This might be a good option for them as well. So kind of think about those kind of issues. Yes, ma'am.
Would you almost like argue as well that, for a non-compliant patient, would this maybe not be a good choice? Because doesn't the patient have to initiate going into the practice to receive the shot?
It could. You have to think about the situation though. So if they have like someone who is responsible for their health care, that is, taking them to their visits and things like that, but may not be able to, have them take a pill every single day, or if they have an issue where they forget to take their medication, but they still can go in for a visit there, that's something to consider. So, yeah, there's lots of there's a million different patient situations, and so you just kind of have to go on a case-by-case basis in a lot of situations. But some people, they just don't want to think about taking a pill every day. So they're like, just give me a shot and I don't have to worry about it, right? So it can be beneficial to them. The other thing you have to consider is, there's a little bit of bleed over there. Basically, this is kind of an oil-based kind of suspension, is why you put it in the muscle, and it has that nice depot effect that kind of slowly releases over time. Even if the person misses it, it's not 90 days to the actual day. They still have a little bit of bleed over effect, which is kind of nice. So even if you're worried about that compliance, they come in a week late, they probably still have that effect around long enough. But the other thing you'd have to consider is, what if the patient wants to become pregnant? You need to get them back on a normal cycle and actually have them start to ovulate again. If you have this drug sticking around in the muscle for longer than a 90-day period, they may not be able to ovulate, or may have a delayed return to ovulation. So we'll mention that a little bit later on. But just note that you have to think about, okay, well, when's the patient, are they expecting to want to get pregnant anytime soon? Then returning to ovulation is going to be important for that to occur, and so they have to think about that. So again, that's why you have that kind of prolonged anovulation, and some patients will have some amenorrhea associated with that as well. And again, anytime the estrogens are contraindicated, this would be a good option where you can just give a progesterone by itself, like medroxyprogesterone. So kind of mention the near future pregnancies. So it may have some negative effects on blood pressure. A lot of that goes back to the mineralocorticoid effects, because aldosterone tends to increase blood pressure, if anything. And we'll see that androgenic progestins can actually lower HDL, and so it can worsen your overall lipid profile. Okay. So that's kind of the basics for talking about the estrogens and the progestins. Now we're going to get into more specifically talking about their different uses, and so we'll talk about hormone replacement therapy first. So the FDA approved indications we have for these products, and again, these are the most common ones you're going to run into, is if we can treat kind of like more moderate to severe kind of vasomotor symptoms associated with menopause, that could be one indication for using these hormones. If they have any kind of vulvar or vaginal atrophy, this can be very useful as well. So we kind of mentioned one of the drug products we have for our prescription assignment is actually one of these kind of vaginal products that's useful for treating this kind of atrophic vaginitis there. And then also we can use them as an approved indication for prevention of postmenopausal osteoporosis. So again, we mentioned that estrogen in combination with progestin therapy needs to be used for a patient who has not had a hysterectomy. So if they still have an intact uterus, they need to have an estrogen plus a progestin, because that will help to limit that risk for cancer risk there. They can either use it every single day, because again, we're not worried about them trying to mimic a normal cycle. So they can take it every single day and they really won't have any withdrawal bleeding because they're never withdrawing from the medication. Or you can consider trying to make it more similar to like a normal cycle, to where you may have estrogens on day 1 through 25. You see the progesterone start to pick up in the last 10 to 14 days, and you'd have like a drug-free period from day 26 to 30. Again, that would be very cumbersome to write that down on a prescription when you're trying to figure that out. So a lot of these products already take that into account. So these packs, when they come, and a lot of times when you write for a prescription like that, do you write take this pill on this day? A lot of times you just say use as directed, and oftentimes I say shy away from writing use as directed. But in these cases, when it comes to a very specific pack where they're supposed to take here's day 1, here's day 2, there's no need to like get any more complicated than that. So very similar to if we saw like a Medrol dose pack, which is methylprednisolone. Again, it tells you very specifically here's day 1, take all these pills. Day 2, that's fine if you write use as directed for those. But typically you need to be more specific if you're going to be giving something that's not going to be in a package like that. That makes sense. So again, estrogen therapy can be useful if you were just having a patient without an intact, that had a hysterectomy. That would be okay to use estrogens by themselves. Either continuous or cyclic estrogen is fine in those cases. It just depends on your patient. You see, low-dose oral contraceptives, typically you're going to find that as contraceptives tend to have a lot higher estrogen activity than you would see with your typical hormone replacement option. So like 4 to 6 times as higher. So theoretically, could you use normal birth control for postmenopausal women to treat her symptoms? Yes, but the estrogen activity is much, much higher, because again, we're not worried about shutting down their whole hypothalamic pituitary axis. We're just worried about replacing what their ovaries should have been producing otherwise, right? So you get away with that, but then you worry a bit more about the side effects. And so again, typically they'll use lower doses in order to get away with this, right? And keep in mind these different estrogen products, like don't just look at the dosing to get an idea of its activity as a comparison, because some of these come as micrograms, some of these come as different. They have very different potencies, and so you can't just look at the milligram dose of it product and know how potent it is. You need to really compare it based on the product itself and how that kind of lines up with other drugs. So, as I mentioned, with oral options, you're going to have them undergo that first pass metabolism. So that is going to stimulate this hepatic protein. So you're going to find more of the clotting factors being made. You're going to find more of that cholestasis is going to be a risk there, because again, more of that estrogen is going through the liver first, getting metabolized and getting secreted out through the biliary tract. The transdermal products tend to be preferred if they have a history of things like hypertension, they have increased triglycerides, risk for VTE, or cholelithiasis. So it's going to be a little bit better products there. Again, we'll look at some different dosage forms a little bit later on to kind of see how the dosing works with these. Again, compliance can be a good one for transdermal use due to, again, they can leave it on for several days and don't really think about it. And I mentioned intravaginal is good for vaginal symptoms only, as you might imagine. You may still see some systemic absorption. So again, if you have a woman who's having kind of mild vasomotor symptoms, mild hot flashes, but the dyspareunia is really the negative thing for them, you can use a vaginal product, and you will get enough systemic absorption. You may be able to help out with those vasomotor symptoms, but not the same as you would if it was like an oral product or transdermal product, something like that. But you'll typically find that, and we'll look at the different dosage forms that are available. Some of them comes like creams, some of them comes actual like devices that have been implanted with the drug itself. But things like vaginal tablets and rings tend to have more minimal absorption, just due to the fact they're kind of slowly releasing their drug out rather than it being like a cream or gel or something, which is kind of like all right there, kind of ready to absorb from that standpoint. So we'll look at some of those a little bit later. So it's not important to memorize this entire list. The important thing is just to kind of get an idea for the various products that are out there. Again, you can look this stuff up if you needed to treat these type of patients. I just want to kind of give you a feel for the different products that are out there and what you might see. For testing purposes, kind of questions I'll ask, like which product would be best for this sort of patient, So I may say like, patient is postmenopausal or having vasomotor symptoms, but they've had a history of a hysterectomy. What might be the best product for them? And I would show you like an estrogen only one, estrogen plus progestin, or something else. So those would be the kind of questions I might ask where you're selecting the best product for your patient based on their kind of their history, right? That makes sense? Again, it's more important to be able to look at the drug and say, okay, I know this is an estrogen plus a progestin. I know this is going to have this kind of activity. So anyway, So here's some oral estrogen products. Again, you have various kinds here. Conjugated estrogens or Premarin's a very common one that you're going to run into. And notice here that the dose we're seeing, say 0.3 milligrams, 0.625. So you're really dosing based on how they're responding to it. You can start kind of low dose, and then you titrate to see how they're responding to it. If they have any kind of abnormal bleeding or anything like that, lower the estrogen effect, lower that dose some, and try to use the minimal amount as you can in order to treat their symptoms. Again, these are oral estrogen products, so you will worry about things like risk for VTE. You will worry about that, changes in lipids and whatnot. So again, these are all going to be linked up with that oral first pass effect you're going to be finding with these drugs, right? Let's see. Here are some transdermal estrogen products. So again, 17 beta estradiol are probably going to be the most common ones. It is a transdermal patch. You'll find lots of different brand names that are out there, lots of different generic varieties. Again, most of the time the dosing is going to be the same, but this is nice because you may only have to do it, say, once a week or twice a week. They're going to be applying this. So especially with your older patients who may have other cognitive decline, maybe they have Alzheimer's, maybe they have something where they're not really able to be as compliant, these can be good options for them as well, right? So, something you only have to give once or twice a week and can be pretty beneficial. Does anyone know how much, like when you're done with the patch and you take it off, is it all the drug gone off of that patch? There's a lot of drug still left because, again, what is driving that drug transmission through the skin? Concentration gradient, right? So you have to have a lot of drug on that patch in order to cross it through. So again, always remember, make sure they're disposing of these things safely. If they have any kids in the house, make sure they can't get to them, because if a kid picks it up out of the garbage and eats it, they can still get some symptoms from that. Estrogen is probably not going to be a big deal, but with some other drugs, so you think like clonidine patches and things, just remember that that still has a lot of drug on it, can be problematic. One of my favorite calls I ever had to the Poison Center is I had a dad call up. He was near hysterical, and he says, "Oh my gosh, my 2-year-old son just ate a dose of my wife's birth control. She had it sitting on the counter. She's going to take it later," and he went and grabbed it and he ate it. What's going to happen to him? Extremely concerned. So I had to put him on mute, laughed a little bit to myself, took him off mute. I said, "Sir, everything's going to be fine. Your son's not going to turn into a girl, anything like that. Might have a little nausea and vomiting, but if he wants to go shopping later, just indulge him, okay?" He did not get the joke. He was just like, "What? He's going to be okay." Yes, he's going to be fine. One of my favorites of today. Anywho, so again, transdermal products, very useful for non-compliant patients or patients of any kind of memory impairment, things like that. Very good. Some transdermal gels available, some sprays. So again, lots of different varieties that are out there. You'll probably find, if you're dealing with these patients on a routine basis, you'll find 1 or 2 products that are your go-to, and you'll probably just stick with those for the most part. And again, a lot of it is which one's covered by their insurance, etc. So lots of things will go into how you select one of these. Okay. Some vaginal estrogen products. So you'll find that there's some creams that are available here. Again, it doesn't really matter which one you're using, because again, you're titrating to effect for the most part. So again, here's like an Estrogen vaginal cream. Notice here the doses are a lot higher, because again, you're only applying these locally. You may not really get absorption of all that 2 grams when you have that, but typically these are given daily, say for 1 to 2 weeks, and then as you kind of go along, there's more kind of maintenance dosing. So you want to, for this product in particular, you start with a little bit more frequent dosing, a little bit higher dosing, and then you titrate down once their symptoms are kind of under control at that point, right? Let's see. Premarin vaginal creams, again, you'll see that in some cases these will be dosed more cyclically. So for instance, for this one, if you're using it for atrophic vaginitis, you would end up giving it for 21 days and then they're off for 7 days, and that will give basically kind of try to mimic that kind of normal sort of cycle, this normal estrogen effect that we would see typically. So that may be one way you see that being dosed there occasionally. And here's some rings. So again, these would be basically kind of a plastic or rubber sort of ring that actually gets impregnated with the hormone, and that will slowly release. So it's kind of like a controlled release sort of format. And again, you find that these can be implanted for longer in a lot of cases, because they do have a lot of drug that is there. It just releases out slowly. So for instance, this E-string or S-string, I guess would probably be how they pronounce it. This one for 90 days. So you get basically 3 months of use out of it. Do you have a question? Yeah. Unless they start producing their own estrogen, it's probably unlikely that they're going to get back down to baseline, to try to, it could be one of those things where they could try weaning off, try to go like on a drug holiday, and if the symptoms really aren't that severe to them, then maybe they say, "Oh, I don't really need to go back on it," right? So it just depends on kind of what their symptomatology is, what's tolerable to them. in a lot of cases. So these don't have to be lifelong products. It would be something that's, you know, based on patient choice, really. Yeah. So here's a tablet that can be applied here. This one would have to be given more frequently. Those tablets usually will dissolve and be gone usually within a day or so. And then actually one you do twice a week, so you wouldn't have to give it maybe that frequently. So here's some example. Here's like an S string. So you can see it just usually pretty kind of soft, kind of a rubber sort of feel to it, and be applied by the patient or caregiver or anything like that. And usually will kind of be applied right towards the cervix and just kind of stick there, and usually they're fine for 90 days. And if it comes out, you can just reapply it, you know, put it right back in, you're good to go. Some of them, like the Vaginal Creams, will actually have an applicator, so that way you can make sure that you can draw up the appropriate dose, how many ever grams of product that you're using, and then apply that, you know, just insert it and just apply the drug directly to the tissue. So it can be pretty easy to use as well. Obviously, you know, kind of the benefits of these is given less frequently, less kind of messy than having to deal with creams and things like that. So again, a lot of patient preference goes into this. Okay, and then there's some combination estrogen progestin products. So again, this would be better for a patient who still has an intact uterus. You can see here we'd use conjugated estrogen plus like medroxyprogesterone acetate. So again, there's just one variety. Here's one you see like norethindrone. And again, ethinyl estradiol norethindrones, like that's one you'll see with oral contraceptives, but the doses here we're using tend to be a little bit lower than what you would see for typical, like, you know, as a contraceptive. This one, so those ones on the last slide were just continuous products. These are going to be more intermittent products. Here we see that they'll use 1 milligram of estrogen plus, so 1 milligram of estrogen, and then you have this combo here. We have this progesterone there, and you have estrogen alone for 3 days, followed by the estrogen plus progesterone for 3 days, and this would be repeated continuously. I don't know what the benefit of that product necessarily is, but some of these you'll see that you'll do estrogen alone for 14 days, followed by another 14 days of estrogen plus the progestin. There's lots of different varieties out there trying to mimic somewhat of a normal cycle for those patients. Here's another transdermal continuous combined product. So again, those are also available as well. So basically, if you can dream it up, there's probably an estrogen product out there to fit your needs. And then here would be a progesterone product by itself. So medroxyprogesterone, as I mentioned, usually you can either see it as an oral product, but a lot of times you'll see that drug being used as a depot shot very frequently, and just used as an intramuscular sort of agent. Any questions from the first half? Again, some people are questioning, like, well, what's the benefit of using like just a single, you know, continuous dose product versus using you know, biphasic one? I don't know medically if there's any true benefit to one versus the other. It's more based on symptomatology, what's your patient responding to, especially with things like abnormal bleeding and things like that. Like the progesterone can really help to kind of stymie that a little bit. So some patients respond to having estrogen on for the first 14 days and then adding that progestin on board. And again, as I might mention, if you talk to someone like an OB-GYN person who did this day in and day out, they'd be like, oh yeah, obviously you do it, this product for this and this product for that. That's fine. I rarely run into hormone replacement therapy for our little guys over at Nemours. You know, not a whole lot of menopausal women over there, unless you're working with them. So I don't deal with this a lot. So again, it's one of those things where, you know, if you talk to an expert, they might have different opinions, but this is at least the baseline. This is what you're going to see most commonly for the most part. Anywho, there's some other therapies we can use to treat some of these vasomotor symptoms of menopause. So again, if maybe the patient was you know, reticent to start estrogen-based therapy, or maybe they didn't respond super well to it, there are some drugs we can use to help with that vasomotor symptoms, those hot flashes that occur. And we'll talk about these antidepressants in just a little bit, but since I know you guys have already covered them in other classes, I can just quiz you on them here anyway. So we have like our SSRIs that can be useful for helping to mitigate some of these. So like, what are some SSRIs? Prozac, which is fluoxetine, right? Sertraline, which is Zoloft. Celexa, which is citalopram. Good. So those are all good options. And then what are these two? Venlafaxine and desvenlafaxine. Never heard of venlafaxine or Effexor? Effexor, yeah. So these are actually SNRIs. These are serotonin, norepinephrine reuptake inhibitors. Desvenlafaxine, the brand name is Pristique, I believe. And we'll talk about these in the next section coming up. So just be aware that we're going to talk about these. Again, you'll find that typically the SNRIs have a little bit better, you'll see them used more often for like neuropathic pain conditions. So you think about like Cymbalta or duloxetine, that's another SNRI that you see occasionally used for neuropathic pain. So these can be useful. Again, these take time to kick in, you know, so you have to give them 4 to 6 weeks before they can really start to see their efficacy. So think about that. But, you know, if you had a patient who's going into menopause and they also had, you know, depression, this might be a decent option for them. So think about comorbidities as well. Some patients respond to anticonvulsants like gabapentin. Again, gabapentin and then its cousin pregabalin would also be good for neuropathic conditions. So you can start to see how they can there's a little bit of crossover, a little bit of bleed over there. And then for some patients, actually respond well to clonidine. And again, when you see these vasomotor symptoms, what's happening with these patients? Why are they getting these hot flashes? They get that vasodilation, right? So they're having this vasodilation occur. Sometimes you can try to mitigate some of this by using something that kind of helps to kind of regulate the sympathetic nervous system a little bit. So clonidine can kind of help with that, acting as a sympatholytic on those alpha-2 receptors, try to kind of stabilize everything a little bit. So some people will respond to that. If they're hypertensive, this is again a good option for them. Yes, ma'am. Think about it from like a trying to kind of calm down those nerves, like the nerves that are causing the vasomotor symptoms in the first place. You're trying to make them a little bit more hyperpolarized, try to just keep them less active. Again, it's one of those things where, like with neuropathic pain, we don't know the full mechanism for how they're working, but these tend to be somewhat effective. So we'll talk more about neuropathic pain later, but this is why you see that kind of bleed over with these. So again, the full mechanism, we don't really know why it works, but it tends to work for some patients. But if they had, you know, diabetic neuropathies or fibromyalgia, like gabapentin might be a good option to help with managing that as well. So, again, just things to consider. Good test questions I might add, might come up. I don't know. Anyway, okay, so moving into the oral contraceptives. So we've got a lot of options here. Some of these are not even going to be hormonal. We'll talk about a few products that actually aren't even really that drug-based at all in the first place. But anywho, so we have hormonal contraception. So this is where we're using a combination of estrogens and progestins. Why don't we use estrogens by themselves? Right, because these patients presumably still have their uterus intact, and so we don't want to have this endometrial risk happening here. So we have to give them combination products. Could we give progestins by themselves? As I mentioned, yes, absolutely you can. So we'll look at that. So we have monophasic products, which I mentioned is going to be a kind of a constant dosage of both during the menstrual cycle. So we have the same estrogen, same progestin dose the whole time. And the biphasic, which will tend to kind of change the dose of one or both at certain points. So say either at week 14, day 14 or you know, whatever day happens to be. And again, most of these are going to have that placebo period, that last week in there where you're having that withdrawal of hormones that patient can menstruate. In the triphasic, again, this is going to have where the cycle will change twice. So usually like at day 7 and day 14 or something, you may see changes in the dosing there. And then the other option would be just continuous progestin-only therapy. So I mentioned like the medroxyprogesterone shot is a good one. There's also progesterone-only oral products like the mini pill. Anyone ever heard of that? Yeah, so that is another option as well. So we'll talk about some drawbacks and benefits with those products. So their mechanism, as we mentioned, they're going to be selectively inhibiting that pituitary function by feeding back, causing that negative feedback loop to be activated, and basically shutting down that release of LH and FSH. You're going to find that with combination agents, you know, so using the estrogen and progestins, you're going to find, you know, these changes in cervical mucus that tend to, you know, all these things are going to help to mitigate the chances of conception actually occurring. And what you'll find, are these products always 100% effective? No. So again, it's one of those things where even if you're taking it every single day religiously, they may not be 100% effective, right? So this is one of those things you always have to educate patients on. How often is it that patients will take it with 100% accuracy every single day? Not great either. So now you're starting to factor in the human element to it. This is why you can run into issues with contraceptives failing. So again, nothing is a sure thing unless you're practicing abstinence, which would be the only safe bet. Which everyone should do, especially my daughters. I'm going to have them practice it until probably 30, 35. And when they find Mr. Right, then it's fine. No, just kidding. Anyway, so you're going to find, you know, things like, you know, inhibited function of, you know, motility and secretion of the uterine tubes. All these things are going to be useful to decrease that likelihood of implantation and conception occurring there. You're going to find that if you're using progestins alone, they may not always actually inhibit the ovulation, but they will have these effects to try to inhibit that implantation and the actual conception from occurring. So may find some women still ovulate when they're just on progestin-only products, but they should still have some these inhibitory effects going on here. Because again, you remember when the ovulation actually occurs, what is that at its peak? What level or what hormone? Yeah, the estradiol is actually going to be at the highest levels when the ovulation occurs. So that's why you see by shutting down that system with the estrogen that you really have a better way of inhibiting ovulation from occurring. But anyway, so I mentioned that you typically will see kind of a depressed ovarian function when these medications are on board. So it should be smaller, right? So you shouldn't have that hypertrophying sort of effect, a hyperplasia that occurs from the normal LH and FSH sort of influence there. And you typically find that most women will return back to normal menstrual patterns once discontinued. So it may take a cycle or two before they're actually ovulating as they were prior to the medications being on board, but typically this is a reversible phenomenon. Take the drug away, should go back to normal. 75% or so within the first cycle, but by the third cycle, 97% of women should be back to normal from that standpoint. Some people will remain amenorrheic for years occasionally, but it's pretty rare when that occurs. So again, that would be probably a sign of something else kind of abnormal going on in that person's physiology. So, but most people should return to normal by that third period. Anyway, as far as the uterus goes, again, you may find some of these other changes where you actually have hypertrophy and this kind of polyp formation that can happen, and usually thicker and less copious mucus. So again, all these things are trying to help to mitigate some of these the implantation from occurring. Typically, you'll find breast enlargement, and also can suppress lactation, so it could be problematic. So, for instance, if someone is breastfeeding but they want to get on contraception, who's not planning on getting pregnant anytime soon, that could be an issue there. If they're not lactating and able to produce enough for the baby, you might have to switch over to some alternative means of feeding. And then we mentioned the hematologic effects here. We're going to see that increase in clotting factors, decreased activity in antithrombin 3, and so those concerns for thromboembolism come up there, right? So these kind of unprovoked VTEs or PEs that pop up. You may find some women will develop hyperpigmentation, so you get kind of a darker complexion due to a response to this. Some of it may be reversible, but in some cases it may not be. It just depends. Some of it's thought to be due to exposure to ultraviolet light, so this is one concern, especially here when we're in Florida and it's pretty sunny for the most part. And you will see some androgen effects. This is typically going to be more from the progestins, and that can actually cause increased sebum production, so acne may be worse. So as you mentioned, if you think back to the derm section as well, some people actually benefit from oral contraceptive use. Some acne will improve. Some of it will get worse. It just depends on the patient and how they respond to it. So again, everyone's going to be a bit of a snowflake from this standpoint and respond a little differently, and it's kind of taken on a case-by-case basis. So again, we mentioned their clinical uses for contraception. So we'll find that if you take them according to their labeling, the risk is pretty small. They find that combination agents, you have maybe 5 to 12 pregnancies per 100 woman years at risk. So this is with typical use. So this is where you see kind of factoring the human feature there of some non-compliance, missed doses and things like that. So if you had 100 women, you follow them all for a year, or one woman for 100 years, which I don't know if she'd be able to have babies that whole time, but you find basically 5 to 12 pregnancies or so. So again, not foolproof. The only thing you can really do is use either backup forms of contraception or just abstinence altogether. So again, but they're pretty good for the most part. If you had perfect use, maybe only a half to one pregnancy. I don't know what a half pregnancy looks like. Probably pretty weird, but that just goes to show you that the human factor is a big thing here. So again, it's generally only as good as the patient who's taking it for the most part. So the other thing you have to consider, though, is going to be things that are going to interfere with the metabolism or the enterohepatic recycling of those drugs. So we mentioned that some antibiotics can affect this, where they will kill off some of the gut bacteria that is hydrolyzing the estrogens and allowing them to be reabsorbed. That can be problematic. A lot more of it will be eliminating the feces. So as those estrogen and progestin levels drop, you may find that the ovulation may not be perfectly inhibited. And then other drugs that may increase metabolism, like phenytoin, we mentioned, as being an inducer of certain CYP enzymes and other enzymes in the liver, you can also increase metabolism of those estrogens and levels will drop. So again, also of concern, because we mentioned, especially if you have a seizure disorder, these medications, you don't necessarily want to get pregnant, because what are the problems with a lot of those seizure medications? It can be teratogenic, right? So that's one of those concerns where it's like you want to definitely make sure you don't get pregnant, because that influence on the fetus, especially during organogenesis, can be problematic, right? So in some cases, we'll use these products to help treat endometriosis. You'll find that estrogen alone may be sufficient to alleviate some of the pain associated with that. And again, this is another thing where we'll try to use the smallest doses we can to limit the side effects. But typically, you want to, again, to have an intact uterus, adding on that progestin to try to limit that cancer risk associated with that. As far as adverse effects go, a lot of these are going to go back to what we were talking about previously. These may be more pronounced than you would see with some patients using this for hormone replacement therapy, mainly because the doses we're using here are going to be higher, more potent sort of drugs we're using in order to really shut down that HPA axis function there. But certainly, you can see things like nausea, mastalgia, breakthrough bleeding, edema. These are probably the most common one. This typically can be related back to too much of an estrogen effect. And so by using smaller doses, or if you use say like a progesterone with more androgenic effects, that can actually help them mitigate this. This is where you'll start out with one product for your patient. You may have like one drug you go with for everyone basically, and then based on how they respond to it, you may try to change that as they come in. So, and I've actually run into this several times because I'll have patients who will come in, young ladies who are coming in to the ER because they're having this abnormal bleeding, and the doc will call up and they'll say, well, which contraception product should I change them over to? Because they're having bleeding on this product, what should we use instead? And so, we'll talk about different places in the cycle where the bleeding occurs and how we can modify our doses for that. So we'll talk about that a little bit later, but it does come up even in like the emergency room sort of setting occasionally. Anyway, you may find for some people who have migraines, this could make it worse potentially, but usually mild headaches can happen with this. Some small risk of increased cerebrovascular accidents, especially with that kind of clotting effects that we worry about with that. And again, if they find that some people will actually have migraines that will occur when they discontinue therapy. So again, that could be the estrogen withdrawal can actually lead to some effects as well. And then one of the other things you may find for some women is, depending on the product, you may find they may not actually have withdrawal bleeding during that 7-day placebo period. And so, of course, if you were to miss your period, you would automatically think, I might be pregnant, right? So that's one of those things where that failure to have withdrawal bleeding can be problematic, and some people may produce a lot of anxiety or need to buy pregnancy tests every month. They don't want to have to do that, and so trying to switch up products may help to mitigate some of that. So again, other reasons why you may need to switch products, not necessarily because it's ineffective, but because you're not having some of these other side problems with it. Okay, it's more moderate sort of adverse effects. You can see some breakthrough bleeding. This tends to be most common with progestin only products. About 25% of those patients will have some sort of breakthrough bleeding, and also you're going to see this more pronounced in low dose preparation. So it could be a concern with that one. You'll find in some cases that biphasic and triphasic products will decrease breakthrough bleeding, and based on how they're cycling their doses, the actual total monthly amount of estrogen they're getting doesn't really change, because again, it's kind of ramping up the doses as you go through the month. And so some patients will do better and have less breakthrough bleeding in those cases. So again, maybe one case where they will respond better to a triphasic sort of product than a monophasic one. And then we mentioned the weight gain. That's going to be more with progestins that have more androgenic sort of properties, and ones that have higher mineralocorticoid activity, because again, it's going to hold on more fluid, and some weight can go along with that. Sometimes if you can switch to a product with less progestin activity, that might be beneficial, or sometimes dieting, things like that, and salt limitations can be used for those patients. I mentioned that increased pigmentation. Again, some patients will have this. It can be exacerbated by a vitamin B deficiency. I thought that was kind of interesting. So hopefully they're taking a prenatal vitamin or some sort of multivitamin can help replenish that. In a lot of cases, it will be reversible, but maybe slow going. So one thing to educate their patients on. And then as far as the acne goes, you can see this more with androgen-like progestins. But in some patients, large doses of estrogen may actually help to improve their acne. So again, just depends on your patient there. Other things you can see, hirsutism can be aggravated by those androgenic sort of progestins. If you can switch to one that has less androgenic activity, so like I mentioned, the drospirenone is nice because it has anti-androgenic activity, that can be useful by switching them over to that. Kind of interesting one that I don't hear about too often is kind of urethral dilation that happens here. And actually, you can see bacteriuria. So there's some increased risk for having bacteriuria for those women, especially those may be prone to having UTIs anyway. It could be a little bit worse for them. Vaginal infections tend to be a little bit more common, difficult to treat for those patients taking oral contraceptives, and then amenorrhea can happen here. You'll typically find that people are having menstrual problems before taking these products will tend to be more at risk for having these as well, just because again they're already kind of abnormal, so to speak, to begin with. So one thing to concern. Again, a lot of these patients may have things like prolactinomas, or like PCOS is another big thing. We have kind of high level prolactin being released that can inhibit that. Causing amenorrhea, so again, that could be another exacerbating sort of factor there. And obviously severe effects, really worry about the venous thromboembolism. The risk is about 3-fold higher, while even on low-dose oral contraceptives, so again, it's one thing to be concerned with. And the other big thing to tell your patients not to do while they're on these, smoke, don't smoke. Again, you hear a smoker on their oral contraceptives, you really worry about that clotting risk. Typically, you're finding the risk goes up as soon as you're on the product, even from the first month, and remains constant throughout. Your body doesn't really get tolerant to that. It doesn't really ever adapt to it. As soon as you're done taking it, though, once the patient's off of it, you're kind of back down to baseline risk. So that can be one thing to note with that. Again, if they had a hypercoagulable state to begin with, again, they're also going to be a higher risk than your typical normal patient would be otherwise, right? And this risk is only really related to estrogen and progestin. So if you had a patient who had a VTE on a combination product, this might be a good candidate to switch them over to just progestin only. It's like a depot shot or something like that. Some increased risk for myocardial infarction, especially if you had a patient who had, like, say, diabetes beforehand, hypertension, they were obese to begin with, or they're a smoker. Those all tend to be a little bit higher risk with that, especially due to things like, you can see some coronary arterial spasm, you can see increased atherogenesis, things like that. So just be aware if they have a history of cardiac disease, this may be an increased risk you'd be concerned about. I mentioned kind of that risk for cerebrovascular disease, some of that's related back to the hypercoagulability, so it's one thing to be concerned with. And then I mentioned the gastrointestinal problems. You may see cholestatic jaundice. Again, this is something that you typically see kind of early on as a patient is being first exposed to these contraceptives, but typically it will improve over time, and some patients may need to discontinue therapy altogether, and that jaundice may go away after about 1 to 8 weeks or so. And that mechanism makes sense, right? Because we know that the estrogens are being metabolized in the liver, they're being excreted through the biliary tract, but that can lead to cholelithiasis, right? Some patients actually will get worsened depression. So again, certainly estrogen and progestin can affect your mood. Some people have worsened depression that may actually require discontinuation. So one thing to think about. And then there's some risk. Typically have a reduced risk of endometrial and ovarian cancer because the progestin is going to be on board to be able to help kind of limit the estrogen effects. That can be useful. And lifetime breast cancer risks tend to be not really an issue here, but certainly if they have a high risk history, especially like having estrogen receptor sensitive breast cancer, that's something to be concerned about. Okay, so looking at your progestins, this is where, again, you're going to be making the biggest decision about which products to use for your patients. So again, the estrogen content really doesn't change a whole lot between the activities of the different estrogens doesn't really change, and most of them will be ethinyl estradiol. It'll be the most common one you're going to run into from an oral contraceptive standpoint. But the biggest decision is which progestin you're going to use for these patients. And so these are the most common ones you're going to run into, and these are the ones you should be able to recognize on a test. So if I were to, for instance, say, hey, patient's coming in, they're on this particular oral contraceptive, and I would have in parentheses ethinyl estradiol plus say northindrone, but they're having a lot of hirsutism associated with it. What would be a good product to switch them off to? And I may have something like drospirenone listed, and that would be a good option because it has anti-androgen activity, right? So those would be the kind of things I want you to be able to recognize when asked to switch a patient to a different product, or which product might be best for that particular patient. Make sense? Okay, so again, looking at the kind of first generation agents, you have northindrone, norgestrel. These tend to be the more common ones you see in a lot of, especially like products are like off-brand and they are a little bit less expensive. You see a lot of these first generation agents available. They're good because they have good estrogenic activity, progesterone activity, but they tend to have a little bit more androgenic activity as well. So that's one thing to be aware of. Levonorgestrel we'll see available in some emergency contraception, which we'll talk about a little bit later, but that tends to have a lot of androgenic activity, so that would be not a common one you'd see used for systemic use for oral contraceptives, but we'll see some other cases where they can be utilized. But again, drospirenone is really nice just because it's that later generation, really has that anti-androgenic activity, anti-mineralocorticoid activity. So I see a lot of patients being switched over to this. This is what you find like in Yaz and Yasmin, that a lot of patients respond really well to this. They tend to really like it. So that's a nice one. Okay. So again, some cautions here if they have, it makes sense based on the side effects and worries we've already talked about. So again, any risk for cerebrovascular disorders, coronary issues, those would be patients you want to worry about. Again, any unknown cause for vaginal bleeding, because you do want to rule out cancer and kind of scary stuff, and then any kind of estrogen dependent tumors there. Why do you think I wouldn't want to use it in adolescents who've not undergone that epiphyseal closure? Because estrogen actually closes that off, right? So again, that's what you see during puberty. That's why you hit that growth spurt and then you kind of stop because those growth plates are closed. And so if you do it too early, that would be a concern. You could stunt growth potentially. So that's one thing to be concerned about. Be careful if they're on an enzyme inducer. So you guys remember rifampin? We talked about that as an antibiotic. Used a lot for which condition? Tuberculosis. Remember what other one? We use isoniazid. What other condition do you use rifampin for a lot? the cardiac condition? Yeah, endocarditis is another one where you might see that. But phenytoin, but these are very potent CYP enzyme inducers. So again, those are ones you want to worry about because it will drop your estrogen levels. Mentioned antibacterials. Again, a lot of times I just tell people, just in general, if you're on oral contraceptives and you're on an antibiotic, just use a backup method just to be safe. Because again, we already know that the contraceptives are not 100% to begin with. That this tends to be more of a risk for drugs that tend to have a big effect on the normal gut flora. So think like clindamycin, think about like metronidazole, things like that. So those tend to be more ones that are more likely to interact. But just say, hey, while you're on the antibiotics, and typically like if you're on an antibiotic, you might be sick anyway. People are probably not really up to having sex anyway, so probably not a big issue. But yes, sir.
How do you judge whether they've undergone
Usually based on the age, if they're hit puberty, right? It's probably the biggest indicators. I don't know, maybe Dr. Nicholson will have a better answer for that, but that's to my mind, that's what I would think. You know, if they've kind of, I suppose you could check on an X-ray and see if you still see the plates there. But I don't know that anyone's necessarily checking that beforehand. But typically, you know, it's just kind of to mitigate like how young of a patient you're going to use it in. If they haven't hit puberty yet, it's probably not a good option for them, right? Anyway, and obviously if they're pregnant, you don't want to give them more hormones because again, they're going to be producing a lot of their own anyway. So again, that would be another contraindication. Okay, so I mentioned progestin only products tend to be better suited for those that estrogen administration is not going to be recommended in. So again, especially if they're like, you know, really hypercoagulable, things like that, you want to avoid that. They're going to be nearly as effective, but you see more side effects associated with them. So again, they may not always inhibit ovulation, but they tend to be just as effective at preventing conception as combination products. You will find more abnormal bleeding with it, a lot more amenorrhea, but it does tend to get better with time. So one thing to note, and then you will see some delayed return to ovulation. So I mentioned with the combination products, you know, 3/4 of women within the first month should be back to the normal cycle. These tend to be a little bit more delayed. So again, if they're looking to get pregnant really soon, maybe not the best product for them. So another thing, postcoital contraceptives. These are your Plan B, is your morning after pill. You'll find there's a couple of different objects that are different products that are available. There's estrogen, progestin only products, or they may come in combination. And so I'll tell you the most common one you run into is going to be levonorgestrel. This is like your Plan B. So this is the one you can go. Do you need a prescription for these? No. Do you need a prescription for other like oral contraceptives? Yes, you do need a prescription for those, but Plan B you can get without a prescription. So that's again recent within the past say decade or so, but it is something that is beneficial. So if you need it, like it is available. Now the big thing to note if you're going to recommend emergency contraception is that it needs to be used within a good time frame. So for instance, within the first 72 hours. If you're trying to use it a week out, it's going to be much less effective, right? Because the implantation's already occurred, conception might have already happened. But it tends to be 99% effective when used within that first 72 hours. So that time period is really the critical point there. The other big thing to note is if a lot of these products are oral, so if they're taking this, nausea vomiting is a big deal with this because again, they're taking a much larger dose than what you would see normally. So again, usually this is well and above what they would even get in a total months period of levonorgestrel, which this is a progestin they're getting here. So you give that, and that would actually basically cause a lot of nausea vomiting. So they need to take it. Usually an antiemetic can be very useful. Otherwise, if they throw it up within an hour, they need to take another dose, right? Which is already kind of not great in the first place because they're probably going to be still nauseous, but they need to get it in at some point, right? So let's see. So some other potential benefits of hormonal contraception, decreased risk of ovarian cysts, endometrial cancer, ectopic pregnancy, iron deficiency. Again, why do you think that is? If reducing any bleeding, so reducing hemoglobin loss, a lot of or some contraceptive products actually come containing iron. It can be useful as well, especially if you have an anemic patient. One thing to think. Some people experience some benefit to their rheumatoid arthritis. Again, the mechanism I have no idea, but maybe there's some estrogen responsive element there that's being affected. Endometriosis tends to get improved. Acne for some people is better, and then hirsutism may be influenced, so especially if they are having beforehand kind of in a hyperandrogenic state, by giving them these estrogen products, you can shut down that HPA axis and they'll be producing less of their own androgens. So that can be useful for them in that situation. So typically when you're starting these patients off, you want to use a combination pill, and you're going to be using the lowest effective estrogen content available. So usually 30 to 50 micrograms or so of that ethinyl estradiol. Again, I'll post up a document that has all the different products that are available, so you can just see the kind of plethora of options in your armamentarium. But usually 30 to 50 micrograms, and then you titrate based on that. So you see if they're still having any kind of side effects associated with it, and you can titrate up if you need to. Again, you typically give a 3-month supply to start with to see how they're going to respond to it. Gives them time to see what side effects will go away with time. They'll get mitigated, and then by that point they're still having issues. Then you can switch over to something else. So when should you start an oral contraceptive? Does it matter? So I used to think this was magic, but there is some method behind the madness when you start these things. So normally they recommend you start the first Sunday after the onset of menses. What do you think that is? So that way, by the time you get to that first dose of placebo, it should be on a Sunday, right? Because if I started on a Sunday after menses and I'm the first dose of placebo, then I should have that withdrawal bleeding throughout the work week. And then by the time the weekend comes around, the bleeding should be mostly have stopped. And then you would start a new cycle again on that next Sunday. So that way you kind of mitigate some of that bleeding on the weekends, because when people are out and about and being active and whatnot. So that is one of the. Truly matter when you start it? Actually, it doesn't matter what day you start. That is just traditionally what they have done because of that reason. They want to kind of mitigate that weekend kind of effect there. They will recommend if you're post-pregnancy, you want to start contraceptives, 3 to 4 weeks or so post-delivery. They recommend starting then. And then if they had an abortion, you can actually start the first Sunday, and again, that will get them back on that normal cycle of having those kind of period-free weekends there. So when they recommend using an alternative method of birth control, so again, starting up your oral contraceptives using kind of a backup, some people recommend it during the initial cycle. This is it's kind of controversial. I don't know that you necessarily, the failure rate is not that much higher for the first month versus the subsequent months, but some people will recommend, just while the patient's kind of getting used to being on these, that they use a backup form of contraception just to be sure. We'll talk about missed doses, but the lower the estrogen content, the more likely a missed dose is actually going to affect their ability to inhibit ovulation. So that is a concern there. We'll talk about missed doses in a little bit, but that may be an indication to utilize some sort of backup method, wear a condom or whatever it happens to be. What do you think of severe diarrhea? I think that would be a reason to use a backup method of birth control. So if I'm evacuating the contents of my GI tract, those estrogens may not have time to be reabsorbed there, and so that is one concern you worry about. If I'm having a lot of diarrhea, a lot of the estrogens may be flushed away, and then I may not be able to reabsorb them. Those levels drop, and that could be a reason. So again, that's one thing to consider. And then I mentioned antibiotics. Again, these are not 100% like you absolutely have to use backup methods, but it is one thing to consider. Again, better safe than sorry, especially when it comes to having potentially 18-year plus. How much is it to raise a kid nowadays? Like $250,000. My kids will probably be $500,000 each, if I had to guess. Yeah, so I'd be surprised. It's kind of funny though, because for my first child, we tried for like a year before my wife became pregnant, and so it was one of those things where every month it was just anxiety, the pregnancy test. We probably spent more money on the pregnancy test than anything else. And then by the time we got it, it was like, yay, happy tears of joy, we're pregnant, woohoo. And then the second one came along, and we're just like, why are you feeling so bad? Why are you kind of run down? I don't know. Did you take a pregnancy test? I guess. Let's try it. Go to the dollar store. Get the one dollar store pregnancy test they have on the shelf. Come back. She gets it. She's like, well, we're pregnant. Yay! So, very different from 1 to 2, especially when it wasn't necessarily planned. It's a happy accident, I will say. Anywho. So what should you do with missed pills? It was our fault anyways, it's fine. But missed pills. So a single missed pill, you should take it as soon as you remember. So again, even if it's off by a few hours, who cares? That's not really going to be a big deal. So you can take it as I remember. If you miss 2 pills, you miss 2 days, you go ahead and you can double up for 2 days after that. So that way you'll get back on kind of a normal track. So you just double up. You have a little bit of increased nausea, vomiting, but for the most part, they'll tolerate it fine. So just double up on those 2 days. If it's 3 or more, the risk for failure goes up high enough to where you just want to go ahead and just discontinue the rest of the pills. You can just throw a pack out, and you can restart on a new Sunday. They'll have that withdrawal bleeding, but even if it's not a full normal 5 days or whatever, you can then still restart on that Sunday, and you're good to go, right? So again, miss 1 pill, they're fine. Just retake it. Miss 2 days, double up. And if they miss 3 or more, then just go ahead and DC the rest of that pack, okay? Let's see. So if they missed a period, so they have a failure of that withdrawal bleeding, and they're talking to them, they say, "Hey, I'm really concerned about this," and they have no missed pills. They said, "Yes, I've been taking it like every day." You can check a pregnancy test after the first one. So if it happens the second time, the first one you say, "Hey, maybe a fluke." You can check on the second one and see if they're actually having any issues. And there's some cases where you can actually reschedule the menstrual cycle. I thought this was like black magic when I heard about it at first. I was like, we can reschedule that thing? Like what? So this is another term for this is called honeymooning, as you might imagine. So some people, they don't want to go on their honeymoon. They paid for an expensive trip to the Bahamas or something. They don't want to be on their period during that time frame. So they can actually reschedule this sort of thing. And basically what you can actually do is just have the patient recommend they take the continuous active pills. So just go ahead and if they come up on the placebo pills, they skip over those, continue taking it throughout, and that way that you're still suppressing ovulation, you're still suppressing all the cycle. And then when they come back, and then they can go ahead and come off of it for 7-day period and then restart on a new cycle. So that's totally fine. No adverse effects could really be coming back from that. So that's one thing you can do there. As far as stopping pills, you don't really need to have any kind of rest period. I mean, if they want to have a rest period, there's no real need to worry about like titrating down or anything. There's no real glucocorticoid, you see adrenal suppression. You don't have to worry about anything like that with these. You can just go ahead and stop, and it's no problem. For desired pregnancy, though, you do want to have 3 regular cycles prior to conception. Some people, it's kind of controversial, but typically by the 3rd one, they should be back to ovulating normally. They should be kind of ready to hopefully be back to normal. If not, then they probably need to see someone about, they probably had some kind of abnormal issue to begin with earlier. But again, by the 3rd cycle, they should be back to ovulating again. Okay, so this is kind of interesting. So the breakthrough bleeding, you can actually adjust your dose based on when the bleeding is actually occurring, because it's going to be a factor of the estrogen levels and kind of where they're at during the cycle. So generally, you're going to see some breakthrough bleeding as the patient kind of is starting the product and kind of getting used to it. That generally resolves within the first 3 months, which is again why you start with 3 months of therapy, see how they're going to deal with it. If it's still present afterwards, you can actually manipulate the pills based on where the bleeding's at in the cycle. Typically, if the bleeding is happening early on, say days 1 through 14, that usually indicates that they don't have enough estrogen. This is something where you could do either change it over to a product that has more estrogen early on in the cycle, or just has higher estrogen in general. Typically, if they have an issue with their bleeding on that 3rd week, so days 15 through 21, usually indicates a progestin deficiency. So it could be something where you can actually increase your progestin dose and actually help to mitigate that. So that could be an important thing to know where, say, okay, I'm having a lot of breakthrough bleeding. When's it occurring? That can kind of influence you on what type of change you might make to that patient's regimen. Okay, so some miscellaneous products. We have medroxyprogesterone or Depo-Provera. Again, this is just injected, kind of an oily type base, so it has to go intramuscularly, and it will slowly leak out the drug over a 3-month period. And I mentioned usually that duration of effect is about 4 to 6 weeks after the 3 months is up. So again, even if a patient didn't come in, they were lost to follow-up for a few weeks, it's okay. They should still have enough drug around to prevent pregnancy from occurring. But they will have generally pretty irregular menstrual bleeding patterns, and amenorrhea is pretty common for a lot of these patients. So one thing to educate them on. Next, we have levonorgestrel or Mirena. So levonorgestrel is just a progestin-only product, and this is one that can be implanted right here in the uterus. And so again, this would be a procedure they go in for, and the drug itself would, kind of plastic, would release the levonorgestrel slowly over the course of, say, 5 years. So that can be very beneficial. Someone say, they don't want to get pregnant anytime in the next 5 years. This is a good product for them because they don't have to worry about taking any pills. They don't have to worry about patches or shots or anything like that. Once it's there, it's there. And again, they would have to go back in to have it taken out eventually, because it is kind of not something they can just do themselves. There's some cases where I think where it will come out accidentally, but again, if you go back to your provider, they can have it placed again. Let's see. There is the Nuva ring. So this is ethinyl estradiol plus etonogestrel, which is just another progestin. And this one again would be administered intravaginally. Again, this is one where we have 3 weeks in, 1 week out, and that would again simulate kind of a normal cycle for those patients. So again, this is nice because it limits a lot of the systemic effects you have there, which can be beneficial for some patients. So again, if they had a risk of clots, anything like that, maybe one you may be better off to try that. I prefer this one for patients with really good insurance. That's kind of interesting. I just googled like Nuva ring, and that was like one of the top images that came up. So I said, this is too good to not use. There's some different implantable products you may see used occasionally. So here's a progestin-based implant called Implanon. And again, with it being progestin only, you're more likely to see irregular bleeding there, so that's one thing to consider. But it's changed every 3 years, and so you just implant it right underneath the skin. An arm, again, with something like the Marina, like it's nice because it's just kind of locally acting right there in the uterus. You don't see nearly as much systemic effects. This one you still see potentially some systemic effects from the etonogestrel. So one thing to consider from a side effect standpoint. And this one's really interesting. This is a Paragard. This is actually not hormone-based at all. This is actually using copper. So it is intrauterine copper contraceptives. And basically, having the slow release of copper impairs this implantation of the sperm. So basically, by having this local kind of high concentration of copper, and actually interferes with the sperm, and they're not able to really implant and cause pregnancy to occur. And this one's actually changed every 10 years. So again, they can leave it in for even longer if you need someone who really did not want to get pregnant for that period of time, where they're done with kids and things like that. This is a good option for them as well. So actually using heavy metal essentially to prevent pregnancy. I don't know of any case reports of any like long-term issues from copper, high levels of copper. Certainly you can have issues where people can have copper overdoses, but this is not going to cause that by any means. It's a very nice kind of localized sort of effect there, right? You can get this one for pennies. I don't know how much it costs, but actually pennies don't have a whole lot of copper on them anymore. But anywho, okay. So how much time do I have? 10 minutes. All right. So let's talk about a few inhibitors and antagonists here. So again, looking at the process, we already mentioned this. There's several steps along the way that we can inhibit the production of estrogens and progestins. So certainly we can work up here, up top with the GnRH. So if we can inhibit that, so that can be one way to inhibit the release of further FSH and LH. There are things we can do to inhibit things like aromatase from actually converting precursors, steroid precursors into estrogen. So we're going to look at a few ways we can interact with this. And kind of one of the big ways you'll see as well is going to be actually interacting with the actual estrogen responding or interacting with those receptors themselves. So if you had to imagine, where do you think you're going to get the most side effects as far as interrupting this pathway? Up top or at the bottom? Up top, right? So again, this is going to have the most widespread effects across the body if you're interfering with things like GnRH and FSH and LH. Typically, you're going to find fewer side effects if you can just interact with the certain receptors you're concerned with, and that'll be important. So if we can be more specific and target certain receptors, we'll have less side effects overall than we'll see if you were to use something that shuts down the whole system from the top down, essentially. So we have our selective estrogen receptor modulators. I mentioned those before. They find that the first one we have is tamoxifen, where this was a partial agonist, but also an inhibitor, depending on which receptor you're talking about. And so this would be an agonist in the bone and the endometrium, but an antagonist in the breast tissue. So it's able to interact with certain response elements in those tissues, but not others. And so what do you think would be the big risk with using this? So it'd be good for patients with breast cancer, right? Because it would antagonize the estrogen effects in the breast tissue, but where it might be a problem. Yeah, so in the endometrium, right? So you see hyperplasia of that tissue, cancer risk is an issue that. So this would be better for someone who, like, say, had a hysterectomy and they don't have that concern anymore. But we do like the agonism in the bone because that's going to be, preventing osteoporosis, hopefully. So that's a good thing you can see with that one. So we would see this being utilized for things like palliative care for breast cancer, especially in postmenopausal women, or for potentially breast cancer prevention in high-risk women. And again, it was a nice oral product. But because of the fact that we're blocking the effects of estrogen, as you might imagine, you're going to see menopausal-like symptoms. So you see a lot of vomiting and hot flashes associated with that in about a quarter of patients. So this is kind of the first SERM they had available for either treatment of breast cancer or prevention thereof. So also, it can be utilized, and some of these will be marketed towards specifically their bone effects and for prevention of loss of things like lumbar spine bone density and some improvements in their lipids there. So again, not the best one because again, it's still going to be acting as an agonist in endometrium, so there's some unwanted effects from that standpoint. We do have like raloxifene, which is going to be a little bit better because that is going to be acting as an estrogen in the lipids in the bone, but it actually doesn't stimulate the breast or the endometrium. So then you kind of limit that risk with that one because it's going to be no endometrium cancer risk, no breast cancer risk from that standpoint. So that can be very useful. And again, some people will be using this more for osteoporosis purposes than they will necessarily for the cancer purposes. So kind of a dual use you can see for some of these drugs. And here's clomiphene. This is actually an agent that I mentioned briefly here because it's actually an older partial agonist drug, a pretty old drug, but it's going to help to inhibit that feedback loop. And so some people actually use clomiphene as an ovulation-inducing agent, kind of interrupts the system and will kind of help it to restart and hopefully produce ovulation. So you'll see some women who have difficulty conceiving, they may get a dose of clomiphene to try to help restart their ovulation cycle. We have another example is danazol. This is actually a weak progesterone agent, androgenic, and has some glucocorticoid effects. And so you'll actually find that this is working to activate that negative feedback loop and will suppress ovarian function by inhibiting that LH and FSH from ever surging and preventing the ovulation there. Used occasionally for treatment of endometriosis. Usually you'll find some improvements within, say, 3 to 12 months or so. And then actually it's interesting, you'll see it used occasionally for some other hematologic conditions. Again, the exact mechanism for that may not be known, but we do know that it is useful for things like hemophilia, ITP, which is idiopathic thrombocytopenic purpura, may see it used occasionally. So there's some off-label uses that don't really relate back specifically to its mechanism there. But as you might imagine, have more androgenic effects. If you were estrogen-like effects, you're going to see a lot of the side effects, so like deepening of the voice, decreased breast size, hair growth, things like that. So it kind of makes sense based on the mechanism there. There's an anastrozole or Arimidex. This is going to be actually an aromatase inhibitor, so you're going to see more. This is working higher up than like the SERMs did, so you're going to see more side effects from lack of estrogen. And so this is usually going to be used more for patients who are more reticent to use of things like the SERMs, or they're not really being that effective anymore. These are going to be kind of working higher up, more side effects, but better for more like say treatment-resistant breast cancers and things like that. We also have letrozole and exemestane. Exemestane is going to be kind of the worst for this because it's going to be inhibiting the aromatase enzyme irreversibly. It's kind of the most potent effect there, and you're going to see the most kind of menopausal symptoms develop from this. So again, it can be used if patients could not receive tamoxifen anymore. It could be a good backup for that. But you also have a lot of risk for fractures because again, there's no estrogen activity with these drugs because they're actually inhibiting the actual production of estrogen. So that's it for our section. Do you guys have any questions on that? So I don't have to talk about that for another year. It's great. It's like I always come in. I always feel very apprehensive because I'm like, I feel like I'm talking to the choir, and you guys are like, yeah, I know all this stuff already. I have this going on all the time. What are you going to teach me? And so I realized that's not the case. So I really try to gear this towards the guys so that way you guys can be more familiar with things and better treat your patients. So anyway, any questions I can answer for you? Okay. One thing I wanted to mention. So the prescription writing assignment. This is meant to be a self sort of kind of a lone kind of project. So I understand people are going to probably work together. Despite what I say, I can't really police that. But please do not go to your advisors or other professors for help on these. The idea is that you go and look up how to do this yourself. You go and look up the drug information. One important thing to note is if you're looking for products and actually how they're available, if you look through UpToDate, which is linked up to Lexicomp, there's a section called dosage forms. You can actually go and see what commercially available products are, the size tablets that are available or the concentration of certain suspensions and things like that. That's where you can find that information. So please work on this yourself. Again, it's supposed to be a learning exercise because you're going to be out there writing prescriptions one day. So I want you to feel very confident by the time you get out there and on your rotations and whatnot. Make sense? Okay. Any other questions or anything? If not, I will see you guys on Friday.